Welcome to part 4 of Caring for Children with Cancer. This video lecture and the next one is going to address nursing management. We'll begin with the nursing diagnoses that are appropriate for a child with cancer. At the time of diagnosis, as well as throughout their treatment, they have a risk for infection because they are in an immunosuppressed state. They're at risk for injury. They have no platelets. Their hemoglobin and hematocrit are so low that they're short of breath, and they may fall from weakness. A child who has a retinoblastoma affecting one eye is only seeing out of the other one, and has a risk for fall. A child who has an osteosarcoma and needs to have a leg amputated, they're at risk for injury. These same children have a disturbed body image, and then throw the chemotherapy on top of that, and they're going to lose their hair. Children who have cancer have imbalanced nutrition. Part of it is the illness itself, and the other part of it is the treatment that we're giving them. The child and the family know very little or nothing about cancer. And remember, they were doing their routine activities of daily living, and 24 hours later, we've thrown that word cancer at them, as well as we're going to begin treatment also. It makes it hard to cope. So we have a lot of teaching to do in a very short period of time. These children are at risk for impaired skin integrity. Some of that is related to the cancer itself, and some of it is related to the chemotherapy as well as radiation therapy. Some of what we do to these children causes acute pain, as does their cancer. And some children have impaired physical mobility because they're either too weak and tired from the cancer, or they've had a limb amputated. It takes a special nurse to take care of a child who has cancer. There are a variety of roles. One of them is to administer the chemotherapy. So these children have the roadmap, and the nurse needs to be able to read that roadmap and follow it on a day-to-day basis. At the same time, the nurse has to monitor for the side effects of those very same agents. And you know that these are toxins, and they go after the cancer cells, but they go after normal tissue as well. And we'll address some of those side effects coming up. The nurse needs to protect the child from injury, and some of these injuries are related to the bleeding. Administer blood products. Our typical transfusions for the HEMONC kids, and HEMONC means hematology oncology for those of you who are not familiar with that term. We give packed red cells and we give platelets, and usually you'll be giving 1 or 2 units of the packed cells and many units of platelets. We need to manage the side effects. So first you're going to monitor for the presence, and then you're going to manage them. You need to develop a good relationship with the child and family. They're going to be on your unit for a long time, and they're going to be coming back and forth for their treatments. They need a lot of psychosocial support, and then monitor the lab values. Typically, when they're going through their chemotherapy, they're having labs sent off every single morning. And so you need to report this to the other nurses as well as the physicians when they're making rounds, and alert the physician or nurse practitioner when you have any lab values that are in the danger level. Because these children are immunosuppressed, they are not going to exhibit the typical signs and symptoms of infection that you have become used to. Redness, warmth, tenderness. They're not going to show that. Remember, they hardly have any white cells. So if you do see redness, that child has an overwhelming infection, and just about every white cell they have in their body is at that infection site. We always check their immunization status to make sure they're up to date. And if they're in the cycle of still needing the routine childhood immunizations, we're not going to give them anything that is a live vaccine. Keeping in mind that these children do not exhibit the normal signs and symptoms of infection, do know that they will get a fever, and that might be the only sign. So we have standing orders that if they have a temperature that's over 100.5, we are to obtain cultures, and our typical cultures are going to be blood cultures and urine cultures. And then if the temperature is over 38.5, which is about 101, a little more than 101 degrees, then we're going to initiate antibiotics. Many children are getting several antibiotics They might be getting antivirals and antifungals. And so you will be so busy. Think about it. Blood products, antibiotics, antifungals, antivirals, all for the same kid. Some of them need to be infused over an hour, so you are giving them back to back to back to back. This is a child that's going to keep you very busy. Remember that normal illnesses can be deadly to a child, so we have to be very careful about who comes into the room to see these kids. And anybody who's sick, they're not coming. When this child goes home, we want to teach the family and the child that they need to avoid exposure to crowds. So they shouldn't go to the shopping mall. They shouldn't see movies in a movie theater. There's way too many people in there for a long period of time. Some of them are allowed to go to school and others end up being homeschooled. We want them to avoid exposure to plants, birds, and fresh fruits and vegetables because they might have bacteria on them that could cause harm to the child. If they're going to eat fruits and vegetables, we need to wash it very carefully with soap and water. Additional things that we do for immunosuppression is give GCSF. You may have heard of it, called Neupogen, and this will stimulate the bone marrow to produce white cells. And then we have Epogen, which stimulates the bone marrow to make red cells. If the child has been exposed to something, then we might give them IV immunoglobulins. Most children are put on prophylactic antibiotics in the form of Bactrim DS, and they will take it to protect them from getting pneumocystis carinii. When they take it, it's typically on a Sunday and a Monday only. They'll take it twice a day for those 2 days. If they have something that we're treating that's active, then they're going to be getting the routine every 6 hours, every 8 hours, or every 12 hours, whatever the drug is supposed to be given based on its half-life. You must practice impeccable central line care. For me, sterile gloves are going to be used. I'm not going to use the gloves that are just in the wall, on the wall, those boxes. You need to be on alert for signs and symptoms of septic shock and monitor your lab values. So for immunosuppression, we keep our eye on the white cells, but we also look at the H&H and the platelets because that's going to tell you how suppressed that bone marrow is. And then once again, transfuse blood products as needed. The nurse calculates the absolute neutrophil count, and that is abbreviated ANC. And the formula is the percent neutrophils plus the percent bands times the white blood cell count equals the ANC. When the child is going through chemotherapy, they want them just about at 0. So when they're at 0, they're at the highest risk for getting infection. So of course, you are not going to see the typical signs and symptoms. I can't reiterate that enough. So you can pause the video lecture for a minute and just go through these numbers and make sure that this math is right. So this child has 800 white cells. 800. And what's the norm? 10,000 to 15,000. Wow, 800? We've had many a child who've had 100. 100 tiny little white cells in their entire body. So for that child, we put them in what we call reverse isolation. We are protecting them from everybody else instead of us putting somebody in contact or droplet where we're protecting ourselves and the other patients. The CDC no longer recognizes the term reverse isolation, but we definitely use it in HEMA. It's hard for the child and the family because they are cooped up in this room. So we make that room look very lively and like their own home environment. Limit the visitors that come in. They're not going to be able to go to the playroom, so the playroom is going to come to the kid. When their ANC is near 0, we might ask the family, even though they've been with this child forever, to still wear a mask, and you will be asked to wear a mask. Provide diversional activities for this child, and you can see that in the picture that the child is drawing on the window, and we just gave him little markers that can wash off the window. Child Life will go in and visit this child as well. Be sure to care for the parents as well as the child. This is very stressful for them. Oftentimes they're not going home. So give them fresh towels, soap, give them the permission to take a break. Go down to the cafeteria, get some coffee, walk outside. They need to take care of themselves as well. We treat the side effects of our therapies. So thrombocytopenia, you need to implement bleeding precautions. For our teenagers, our girls, don't shave their legs with a straight edge razor. For our boys, don't shave their face with a straight edge razor. They should use an electric razor or consider not shaving at all. Give very good mouth care, but we want to use a soft bristle toothbrush. No rectal temps are allowed, and then avoid trauma. So this is a kid that you're not going to let ride around on a tricycle in circles on the floor. Give them soft toys and quieter activities. When we do a venipuncture, you want to put pressure. For nausea and vomiting, our typical medication is Zofran. Ondansetron is the generic name, and it's 0.15 milligrams per kilogram per dose. And this can be administered either IV, push, or it can go over the pump. Some of them will only get it prior to their chemotherapy, while others will get it around the clock, and that's what ATC means. We're going to give them a fairly bland diet and ask them what sounds good to eat, and also ask the child and the parent what has worked for them in the past to control the nausea and vomiting. So this ends the first part of nursing management, and we're going to move on to part 2.